So at Ilara Health, we're building a technology-enabled primary care model for Africa, whereby we bring financing, flexible financing, in the shape of equipment, but also digital assets into existing, very small, very fragmented primary care medical practices across the continent. We start by the challenges of our customers, who are those very, very small fragmented clinics. And when I started Ilara Health, I spent a lot of time meeting clinicians and I'm asking them, what are the pain points? And they were saying very often, we have every day expecting mothers coming and requesting a scan, an ultrasound, but we don't have the money to purchase the device, ultrasound. Or we have diabetes patients coming and we need to send them to the public system or the private care where they can't go because they don't have money. So we are solving those problems, those pain points, by bringing the equipment and a digital platform. But the challenge is that it's extremely fragmented space with about 10,000 small clinics across a massive market in Kenya and about 200,000 across the continent. So going door to door, understanding the problems. Also, it's a completely out-of-pocket system where people pay a couple of dollars every time they go to a clinician. So the lack of insurance is another big challenge. So our approach, we work with the clinicians. We're not working directly with the patients. We enable this mom and pop shop, the nurse, there's no doctors, by the way, there's nurses running those clinics. So we enable this clinician entrepreneur to better perform what she wants and needs to do, which is deliver a better quality of care by plugging assets, or physical assets, equipment, diagnostic devices, furniture, fridges, computers, but also by plugging digital assets or platform and helping the clinician entrepreneur to build up her business and deliver what she knows and wants to do, which is care. So we've been working since the very beginning of Ilara with about 1,500 of these 10,000 small, privately owned small medical clinics in the outskirts of the cities. We've been serving over, I would say, 1.5 million patients going every month through those clinics. And what's really important is that the clinicians like what we do because they see that they perceive the value. We have a very high NPS. The clinicians can increase their revenue and then can deliver lower cost diagnostics and lower cost services to their patients. But I think in the same time, what's extremely exciting for us is that we see the opportunity and the potential of going pan-continent, pan-Africa, and expanding what we do in one market into the rest of the continent, where the problems are very, very similar. The problem is very similar in a number of countries. I would say except South Africa and maybe a couple of Northern African markets, we see similar problems. And the biggest problem is fragmentation. So when you have, I'll give you an example, in the whole England, if you Google how many GP practices are in England, not UK, just England, probably 6,000. Kenya has 20,000, 10,000 private, 10,000 dispensaries, public dispensaries. So extremely fragmented. Fragmentation means none of them is big enough to make a difference. So other countries are actually have the same structure. On the patient side, it's completely out of pocket, so those people pay out of pocket. They make $5, $10 a day as a family, so obviously they pay very little money for the healthcare. So those two together make a very similar, markets amongst the kind of, I would say, sub-Saharan Africa. It's a good question. So in my opinion, public health does not need to be government health. We do public health. We deliver public health, but privately financed. And I think it needs to be, there is a place where the government healthcare and the privately financed healthcare can work together. Each of them has its own target and his own benefits. Specifically in Kenya, public healthcare is great, is good at the hospital level. The challenge is most of the people, the care starts at a chemist, at a pharmacy, and goes to this primary care before it ends, if it ends at a hospital level. And at that level, in those massive outskirts of the African cities, there's mostly privately owned small clinics, and that's where the private care, the public healthcare privately financed, has its place. I think it needs to be an acknowledgement, right? And I see, like in a country like Germany or in Germany, in Europe, I see, there's a mix, right? There's a public funding going into private GPs who deliver care, and they work, they are paid by the government and then by the national health insurance, right? So it's a mix, it's embedded. I'm not sure in Germany, but I come from France, and in France, you go to a private doctor or to a public doctor, doesn't make any difference. You don't pay because it's covered by your insurance. In at least in Kenya, we see a cleavage, massive cleavage between the public, the government care that the government, advocates, and the privately owned primary care, which is a different space. And there is not yet enough, I think, acknowledgement that those two different systems can become or should become one, both from a data perspective and from an integration from the means, etc. And also from outside funding. Very often we hear about, aid money or grants going to the public sector more than going to the private sector. And I think this needs to change to enable both sides. Look, those countries are extremely resilient, right? Those people do not have, if they don't go and sell something in the street, fruits, veggies, whatever they sell, furniture, whatever they make, they can't survive, right? They can't bring the money to feed their kids the next day. So yes, COVID had an impact on the provider side, so less people went to see a clinician and they rather stayed home or they stayed in their neighborhoods. So for a couple of months we saw a decrease in the patient flow in those providers. But this went up very, very quickly, unlike in the more developed part of the world, which suffered for 2 years. So I think it was rather beneficial because this kind of triggered an alarm signal that healthcare in Africa and in emerging markets needs to be tackled. It needs to be tackled over and above just the infectious diseases. There will be another pandemic. We don't know if there is going to be a virus pandemic or a metabolic pandemic, but this has been an awakening signal and to solve those problems. I think there's a lot of reverse innovation. I mean, it's funny, when I came to Berlin a couple of days ago and I wanted to have breakfast, and I didn't have cash because I don't have cash in Kenya. In Kenya I pay through M-Pesa. I only had a credit card. And the breakfast place didn't want, they said, no, it's cash only. I didn't have cash, so I had to run, find a cash machine. So that's an example of innovation which happened in certain emerging markets, Kenya specifically, where those countries actually are more advanced on certain things like payments than some of the European countries. Same in our case in healthcare. The way we started Ilara Health is by building those mini micro laboratories using third-party blood test devices, printer size, connecting them, cheaply source them, and performing blood tests at a fraction of the cost that you or I would pay here in Berlin or somewhere else in Europe. So there's a lot of learnings to how to, specifically for healthcare, how to bring innovations which are much more affordable to solve the cost of the healthcare in the developed world, which is just ramping up. There was a takeaway, maybe it wasn't on partnership yesterday, there was one big event on wellness. And one of the speakers was saying, in Kenya, people pay $10 for sugar per month, but they don't want to pay $5 to have the national health insurance. And this is one of the reasons why the metabolic pandemic is just growing. And now, is there anything? So, kind of the learning here is that we need to do something about the long-term health of those individuals, which is not just a virus or another virus. It's actually much deeper than that. It's actually really metabolic. It's what people eat, how people live, and we see this in our data points. In terms of partnership, I think it's just I think there needs to be a lot of awareness brought in those countries in terms of how can you improve the whole healthcare system, not just the hospital care or a sick care. Because we need to move in general in Africa, but also in Europe. We need to move from a sick care system into a preventative care system, because we just can't continue feeding a care system which is focused on fixing things way after they happen, when maybe too late. So how do we fix the things before they happen or at a very early stage? I mean, even if you look at how the food is donated in Africa, right? I mean, there's rice, sugar, and vegetable oils, right? So those foods which are donated to people, which is cheap carbs, does only, increases the metabolic pandemic instead of, they feeds people obviously, which is good, but in the same time feeds people with very cheap and very low quality. There's no proteins, there's nothing else, right? So is that a solution? I don't know, but I think we need to solve this problem sooner than later, because this is going to completely destroy the healthcare of entire populations. I think we are aware at least in the western part of the world, that we need to build a better earth for our kids to live in a healthier and less polluted world. But this is not enough, because the western world is just a small chunk of the whole global population, right? So how do we bring this awareness in places where, number one, people don't really think about quality of the air, or quality, or not throwing garbage, or how having a better world, but think in terms of like, do I have enough to survive the next day, right? So it's a very complex thing, because theoretically, being cleaner in terms of pollution is also more expensive. But how do we bring this how do we convince people to do that in countries where they literally live a couple of dollars a day, so they care more about the subsistence and the very, very basic needs? So I think that's something that needs to be sorted, and I don't think that can be sorted at the local level, because there's not enough money at the local government levels to solve these problems.